Hi, my name is Rishi Ghosh. I'm an ICU physician. Welcome to my channel where I like to discuss topics at the intersection of life and medicine. Today, we're going to talk about the blood gas. Now, this is a topic that has plagued generations of students, including myself. But I'd like to share with you a simple, easy to understand approach that can be applied right at the bedside without extra thought. It's an approach that I use even today in my clinical practice. Also, it combines many important physiologic concepts all in one. I hope you find this video helpful, and I hope it will help make you an excellent clinician. Let's begin. So what is a blood gas? Well, you probably already know a blood gas is a sampling of blood, either venous or arterial, that we send to a chemical analyzer to derive four parameters: the pH, the PCO2, the PaO2, and the bicarb. But that doesn't really tell us what it's good for. How does it help us? The best definition of a blood gas is a metabolic vital sign. Yes, a metabolic vital sign. We have 5 clinical vital signs that you are probably already familiar with: the heart rate, temperature, blood pressure, saturation, and respiratory rate. These are indicators of how well the body is functioning. Well, a metabolic vital sign will tell us internally how the metabolic machinery is functioning and how well it's able to maintain homeostasis in that system, in that human body. And that's why in acute care medicine, be it emergency medicine or critical care, understanding blood gases is literally, vital to caring for that patient. So as we discussed, the blood gas is an indicator of the metabolic health of a patient, a metabolic vital sign in other words. And it is an indicator of how well that system, that patient, is maintaining homeostasis. So how does it do this? Well, there are 2 organs that are at the center of balancing the blood gas: the lungs and the kidneys. And they do this by maintaining the CO2 bicarb equilibrium. We call this compensation. So for instance, if we have a patient that is suffering from a medical condition that is producing acid, for instance, maybe the patient has diabetic ketoacidosis, that will cause the patient to attempt to compensate by increasing the rate and depth of breathing, that is the minute ventilation. So they may have something called Kussmaul's breathing to try and eliminate the excess CO2 production. And on the other hand, the kidneys will be attempting to excrete excess hydrogen ions in the form of ammonia. So this is the process by which the body attempts to regulate the blood gas, defend pH, and maintain a homeostatic environment for all of the cellular machinery and organ systems in which to function. Okay, so with all of that in mind, let's talk about some of the indicators, some of the parameters that we measure in the blood gas. The first parameter is the pH, also known as the power of hydrogen. I guess some people might know that. So what does pH really indicate? Well, a normal pH, a balanced pH in a human is 7.4. 7.4 indicates that the body is maintaining an equilibrium which is permissible for all the organ systems to function, the cellular machinery can work as it should. Now, that doesn't necessarily mean that there's no pathologic process going on behind, because as we discussed just earlier, the lungs and the kidneys can sometimes compensate. They can work overtime to try and maintain and defend a normal pH. But you can be sure that if the pH is in the normal range, around 7.4, that the body is compensating, it is maintaining some equilibrium, some balance that allows that the machinery of the body may continue to function normally, and that the patient is not in imminent danger of decline or death. Now, pH can obviously deviate from a normal baseline of 7.4. It can be elevated, so we can have a pH that is alkalotic. Maybe the pH is 7.5 or even 7.6, which would suggest that there is an excess amount of buffer in the system, bicarb. And then the question might come to the clinician, to the person at the bedside, to think about what are the processes that are causing the excess amount of bicarb to be in the system. One example might be a contraction alkalosis, where the patient is being overly diuresed and the concentration of bicarb is getting super concentrated, and then that patient becomes alkalotic. Is that dangerous? Well, there's some debate amongst different clinicians, but in my opinion, having an excess amount of bicarb is not in and of itself a dangerous clinical state. I think it's important to identify and understand why bicarb may be elevated, but is not something that indicates that that patient is at imminent risk of a death or a bad outcome. On the other hand, a patient may be in an acidotic state. That is, when the pH falls well below 7.4. Some of the lowest pHs that I've seen are less than 6.8, and this is the limit of most blood gas tests and the analyzer. When a patient is in an acidotic state, it means that they're in a state of decompensation. Essentially, the lungs and the kidneys are now failing and unable to defend the pH in that patient. That patient has an underlying pathophysiologic process that's producing increasing amounts of acid, and this indicates that they are progressively moving towards a state of non-survival. In other words, they're at risk of death. So the way I use the pH is as an indicator about how sick that patient is. If they're increasingly acidotic, that means they're in a state of decompensation and the risk of death is very high. These are the patients you want to identify early on and intervene swiftly, because that's when you can save a life. The next parameter that I would like to discuss in the blood gas is the pCO2. That is the partial pressure of carbon dioxide. Carbon dioxide is a product of cellular metabolism produced through the Krebs cycle. This is a combustion reaction. It is a byproduct of metabolism, of using muscles, organ systems, and maybe even your brain. Now, the organ that is most responsible for the elimination of CO2 is the lungs. So really what pCO2 is indicating is the functioning of the lungs, how well it is able to expel carbon dioxide from the body. Now, a normal pCO2 is 40 millimeters of mercury. In states of overcompensation, perhaps the patient is breathing faster with deeper volumes, so increasing minute ventilation, like that example I gave earlier of the patient in diabetic ketoacidosis. They're revving up their respiratory system to increase the elimination of carbon dioxide. The same thing happens in people who are exerting themselves in strenuous activities, such as marathon runners. This is a sign of, in fact, healthy lungs. It takes a healthy set of lungs to be able to get rid of CO2 and push your pCO2 levels in your blood to low levels. Some of the lowest levels I've seen are less than 20. On the other hand, pCO2 can rise. This is a state of decompensation if the pCO2 is increasing above 40. This indicates inadequate ventilation. That means your minute ventilation is dropping due to depressed respiratory rate or depressed tidal volumes or just lung pathology. Many disease processes can interfere with one or both of those parameters, reducing minute ventilation and increasing CO2 in the system, leading to a hypercarbic respiratory state. When I approach the differential diagnosis for hypercarbic respiratory failure, I prefer an anatomical approach. I suggest you think about the stick figure. Starting from the top, we can think about processes that affect the brain, which can be drugs or toxins. Examples could be opiates. Alcohol in high doses, for example, can all act as respiratory depressants. Trauma, intracranial hemorrhage, increased intracranial pressure, putting pressure on the brainstem can depress respiratory rate and strokes in this area as well. Moving downwards, if we come to the neck, we can think about spinal cord injuries or swelling around the spinal cord that can impair neuromuscular control of the diaphragmatic muscles and accessory muscles of respiration. Even further, neuromuscular disorders like Guillain-Barré or myasthenia gravis or damage to the phrenic nerve can cause hypoventilatory states. Chest wall disease processes such as chest wall edema from that long-standing ICU patient, or perhaps there's scleroderma, which reduces chest wall compliance, can all lead to situations of high CO2. And finally, anything that can affect the lungs, be it pneumothorax, pneumonia, pulmonary embolus, or even asthma or COPD in that long-standing smoker. So all of these things can cause elevated PCO2 and lead to a hypercarbic state. So the third variable that we can derive from a blood gas is the PO2. That is the partial pressure of oxygen in the blood. As we discussed earlier, a blood gas can be drawn from the venous side, in which case you would obtain a PVO2, V standing for venous, or on the arterial side, a PaO2, A being arterial. And this is an extremely important distinction to be made. A venous blood gas driving a PVO2 has questionable sort of utility. The PVO2 is not wholly useful. It's maybe up for debate, but for simplistic reasons, it's not a number that I use frequently in the management of my patient. On the other hand, a PaO2 can be immensely useful for helping me understand the ability of a patient to oxygenate. Okay, so let's take a closer look at the heme-oxy dissociation curve. So this is a sigmoidal curve, as you can see, and it's relating the percent of hemoglobin saturated by oxygen, the uppermost number there is 100%, to the PaO2, which is along the y-axis, and that's an infinite scale measured in millimeters of mercury. So what are some of the important points to note along this curve? Well, if we take a healthy person, we'll note that a hemoglobin saturation is about 100%, so that's by that pulse oximeter, and that relates to, generally speaking, a PaO2 of about 100 millimeters of mercury. So this is a healthy person with healthy lungs and not under a physiologic stress. Now, if we were to take a person who's starting to desaturate, where do you desaturate? Well, it happens to be at around a PaO2 of 60 millimeters of mercury. And this relates to a hemoglobin saturation of 88 to 92%. So this is commonly why we will say in patients to titrate oxygen to 88 to 92% so that they are sitting more along that inflection point. We also use it as a marker to often wean ventilatory supports in an ICU. Now, what happens further down on the y-axis? So if we're moving further along the PaO2 scale, well, now we're getting into an area where we're actually pre-oxygenating. So this is where anesthetists like to live, I guess. So in the OR, they will often pre-oxygenate a patient before intubating their patient. This gives a reserve, a PaO2 reserve in the bloodstream before the patient starts to desaturate, and is therefore a very important strategy during intubation to buy some time to prevent desaturation and adverse consequences in the patient. Going even further than that, it's possible to put a patient in a dive chamber and increase atmospheric pressure to increase PaO2. And in those cases, PaO2 can reach 3,000 or 4,000 perhaps. So to recap, what strategies do we have to increase the PaO2 and therefore maximize hemoglobin saturation? Well, one, we can administer increasing amounts of oxygen. Room air is 21%. We can go all the way to up to 100% through ancillary oxygen delivery devices, be it a bag valve mask perhaps, or just titrating up the FiO2 on a mechanical ventilator. On the other hand, we can increase PaO2 by increasing atmospheric pressure or a driving pressure, and that can be by perhaps diving a patient. The other way to improve PaO2 is to increase the mean airway pressure. So what we are doing is increasing the driving force into the lungs by recruiting extra alveoli and increasing that gradient in the alveoli into the bloodstream. And this we can do on mechanical ventilators in the ICU. So I hope this gives you a general overview of how we can address PaO2 and interpret this in the context of an arterial blood gas. The fourth parameter measured within the blood gas is the bicarb. Now the bicarb is the principal buffer to regulate pH within the body. The organ that's most responsible for adjusting and regulating bicarb is the kidney. It does this through ammonium excretion and bicarb reabsorption. The mechanisms of this are quite complex and beyond the scope of this talk. The typical level of bicarb in a healthy human system is 24 millimoles per liter. When the level of bicarb increases, we become alkalotic, that is a metabolic alkalosis. The causes for this can be loss of acids, perhaps through excessive vomiting, when we lose hydrochloric acid through vomiting. It may be exogenous inputs of bicarb into the body. It can be contraction, so we lose free water through excessive diuretics and get a contraction alkalosis and the bicarb concentration increases. By and large, these types of etiologies are not immediately life-threatening. They do need to still be identified, but they don't necessarily immediately pose an immediate risk to health, especially if the pH is being defended. On the other hand, if the patient is becoming acidotic, the pH is falling, and this is associated with a metabolic acidosis, whereby the bicarb is being overutilized and dropping. This can be a critical state. The differential in terms of approaching a metabolic acidosis first starts with calculation of the anion gap. When we have a positive anion gap, then we can go through the differential of mud piles. I'll write this mnemonic here above that you can follow along. It's also written in most textbooks. Some of the most common physiologic states that we encounter, clinical diagnoses, might be diabetic ketoacidosis, which is part of that mud piles. Many shock states will lead to buildup of lactic acidosis, which is another reason to develop a anion gap acidosis, metabolic acidosis. And as you can see, all of these things can be life-threatening. On the other hand, if the anion gap is normal, we have what we call a non-anion gap metabolic acidosis. And typically this involves GI disruption. So this may be through loss of bicarb through the GI tract, through excessive diarrhea, or maybe a patient has had previous bowel surgery and has short gut syndrome with high ostomy output. So in these types of physiologic states, the GI tract can then develop a role in terms of bicarb loss principally. Aside from GI losses of bicarb, a dysfunctional renal system, so kidneys that have a low creatinine clearance, can also pathologically lose bicarb, resulting in a non-anion gap metabolic acidosis. So to recap, when understanding the difference between anion gap metabolic acidosis and non-anion gap metabolic acidosis, in the former, in the anion gap metabolic acidosis, we have the presence of hydrogen ion. That means there's a source of acid production, and it is important to understand or to identify the pathologic process producing hydrogen ion. In the non-anion gap metabolic acidosis, we have defective organ systems, either the GI tract or the renal system, which are contributing to the loss of bicarb, and there is no hydrogen ion production, therefore no anion gap. Okay, so let's do some questions and answers. So for the first question, well, what is the material difference between an arterial blood gas and a venous blood gas? Well, you know now that the PO2 number is materially different between a venous blood draw and an arterial blood draw. But now you also know that through the heme-oxy dissociation curve, we can extrapolate by and large the PaO2 number based on the hemoglobin saturation. So it is a minority of patients that we actually need to do an arterial blood gas to get enough clinical data to know how to manage that patient. Maybe it is a patient on a mechanical ventilator in whom you're trying to titrate down ventilatory parameters. That might be a reason. It may be to give an indication of how well the lungs are working and to plot that number over time, the PaO2 number over time. But by and large, the venous gas is more than adequate to give us all the numbers we need. pH, PCO2, and bicarb are modestly but not clinically significantly different than an arterial gas. So my answer to this is a venous gas suffices 95% of the time. The second question may be, well, in whom do we draw a blood gas on? This is a great question. So generally speaking, in all acutely ill patients, so this is a patient that looks sick, that has abnormal vital signs, a blood gas can be instrumental in understanding how sick they actually are by examining their homeostatic status and the operation of their metabolic machinery and compensation profiles of lungs versus kidneys. And in some cases, it can also identify occult pathologic disease. So these are patients perhaps with normal vital signs, but you're still suspicious that patient doesn't look well, something is going on. In those patients, a blood gas and perhaps a lactate as well may be helpful in getting more information about that patient. Thirdly, if you have any other questions that I didn't cover in my video, please add them to the comments below. I will try to respond as I can. I'm also open to all of your questions, comments, criticisms, critiques, and compliments. Love to read all of them. If you have any suggestions for future videos, I would also love to hear from you. I look forward to building this channel over time. Thank you for joining. I hope I've been able to illuminate you about the blood gas and its importance in acute care medicine. Thank you, and hope to see you soon.